All right, so Dr. Udager from Michigan, who apparently does both GU and head and neck. I know he's done a lot of research on sinonasal papillomas, which his talk is going to be about at noon, so that should be interesting. And he's provided us quite a number of very nice spinal cell cases of the head and neck, somewhat in the sinus and somewhat in other locations. Let me just grab my little paper real quick. So if you guys want to take control and drive the case, that's fine. Let me know, or I can drive it. I honestly don't care.
It's flash player, so it's going to break either way.
It's going to break either way. All right, so I'll start driving, but I'm not going to tell you. I want you guys to tell me, and I'll sort of guide you through it. So who's number one?
This is my case. This is Rehan.
Okay.
So from, I believe this is 15-year-old male.
Mm-hmm.
So from the lower magnification, I'm able to see fibrovascular lesion, submucosal fibrovascular lesion.
Mm-hmm.
It's composed of very collagenized vascular stroma containing numerous irregular shaped blood vessels. And here's a stroma contains spindle, stellate shaped cells. And yes, and there is variation inside the lesion, like at the periphery. I was able to see numerous small capillary-like vessels. And when we go to the center, the blood vessels become like they have thick muscular walls, and they surrounded by more collagenous tissue.
Okay.
So I was thinking about juvenile angiofibroma, combining the age, the location, and the histological changes. I'm thinking about angiofibroma.
Yeah, so I mean, given this clinical picture of a teenage boy with a nasal mass, you kind of almost think what the answer is going to be,
Yes.
and in fact, that is what it is, right? And
Yes.
so these are fibroblastic stroma and prominent variably sized vessels. So a few points. What's in the vessels?
What in the vessels?
Yeah, what is inside the vessels?
Yeah.
What is this black stuff?
Is it on it?
Or non-human?
Looks like non-human, but is this like packing material?
Maybe carbon.
I heard somebody say it. They don't really pack vessels. Somebody said embolize, right? So these are highly vascular. And so how do patients present?
Oh.
Nosebleeds.
Right?
Patients present with nosebleeds, epistaxis. And so when they cut them out, they're just going to bleed in the field. And so they embolize them so that they kind of sclerose. And sometimes they are necrotic. Like sometimes the preoperative embolization makes them actually like die. But in this case, it's pretty viable. You can see the nice fibroblasts. Great. What is the genetic background of these?
So I was reading yesterday about several studies between GSTM1 loss and juvenile angiofibroma.
Between what?
GSTM1 loss.
Okay.
And juvenile angiofibroma.
Okay, that's new to me. Okay.
And
what else?
It could happen with familial adenomatous polyposis. And I think there's activation of beta-catenin in the stroma.
And so where would you look for beta-catenin staining in these cells?
In the stroma cells, in the stellate stromal cells.
And in what compartment of the cell?
Nuclei, not cytoplasmic, nuclear.
Great. So nuclear beta-catenin expression Excellent. And what other thing do these express?
There is loss of elastin in the vessel's wall.
I'm saying what other, possibly, what other, because there may be abnormally formed vessels, what other things do the stromal cells express?
Vimentin, maybe. They don't express actin.
Anybody else?
Like androgen receptor, because I know
Androgen
there's
receptor.
Yeah.
Yeah,
Androgen
so
receptors.
perhaps that's what makes these come alight in puberty in kids. I don't know. But yeah, beta-catenin and androgen receptor, and maybe there's some novel findings that you found as well. Other comments or questions? I think those are the main points. Okay. Number 2.
Hey, so I'm the one who took this. This is a 30-year-old male with a left nasal mass, and so we've got this like pretty cellular kind of blue mass that doesn't seem to be arising from the epithelium. So if we go in a little bit, I think we've got these like large vessels that look maybe possibly hyalinized, maybe possibly staghorn, and there's areas where it's like more like collagenized and paucicellular than others. You know, let's see, if we look at the cells here, they look relatively spindled, I would say, like they don't look neural to me, I guess. And so, you know, that rules out things like like neural base, like neuroma or schwannomas or, you know, whatever. So I thought this might have been like an SFT. I think it fits with like the age and like some of the like morphologic features. I think he's maybe a little too old, and it doesn't look like what we had previously, like the the angiofibroma, pharyngeal angiofibroma. So, you know, I guess maybe it could be like a hemangiopericytoma, but I feel like it's not that cellular for it. So that's kind of what I thought it was an SFT.
Okay, so 1, do you see like ropey eosinophilic collagen?
No, I don't. So that, I guess that could also rule that out.
So you mentioned, let's get some direction here. You mentioned spindle cells in the background, and you mentioned these larger blood vessels, but okay, let's look on a little bit of a lower power. Do you see any vague kind of architecture to the cellularity around the vessels?
Yeah, they look like they're like, I guess like condensing around it in some ways.
Yeah, they're kind of condensing around these larger vessels. Here even is a nice kind of, right? It's like there's cellular patches and then acellular patches, and then, you know, a large vessel with a cellular patch and then an acellular patch. And so you go and you look in the cellular patches, what are these actual stromal cells doing?
Oh, are they like cuffing around it? Is that what we're getting at here? Or, oh, they're making like little lumens, possibly.
Lumens, they're making little lumens. So look around, right?
Yeah.
When you see spindle cells, right, you have to identify what are they. In the prior case, they weren't making any architectural structures, right? They were just kind of there, they were poking around. But here, look at those spindle cells, right? Like what are they doing?
Yeah, they're making like little lumens.
They're making little vessels, right?
Yeah.
So maybe restructure your thought process.
Okay.
It is a highly vascular lesion.
Yeah.
It is kind of in a architectural organoid pattern. And those clustered cells around the vessels are also perhaps making small vessels. Okay.
Okay.
So you have any other, you want to change your thoughts or get?
Yes, I will change my thought then. Well, I think that this is probably some sort of hemangioma, like, could it be a hemangiopericytoma then? Or I don't think this is like a glomus, or I'm trying to think what else might be. Don't think this is an angiosarcoma, so I think this is a benign vascular forming. Tanner is saying LCH question mark.
Yeah. So I think at this point we've sort of covered all the important and likely things that it is. And so between this and the next two cases, maybe we'll pause and sort our differentials out between the next two cases, and maybe you'll see where I'm going with this. Okay,
Okay.
so let me pause here. And thanks, Tanner, for that comment. So now we have case 3. And all the things you said are probably on this list somewhere, right? Like, because he's giving us differential diagnoses of similar looking things. So probably we're going to come across all of these entities. Okay. Who's got 3?
So I have 3. So it's a sub, like the epithelium is undisturbed. I don't see anything in the mucosa. It's a sinonasal lesion. And then very cellular, very blue on low power, and then a lot of vessels. Some of them, even at the low power, you can see some of them are like thin-walled, but the other are like more hyalinized vessels. And if you go on the higher power, I felt the lesion is like pretty cellular with bland, dark blue nuclei with lack. I didn't see that much of pleomorphism. There is like the cytoplasm is eosinophilic to a little bit clearing. There are certain areas.
Yeah.
So my diagnosis for this one was glomeangioparasitoma or hemangioparasitoma.
Right. So it's great. In this case, yes, you have those dilated branching vessels, but the cells in between them are like sheets, right? They're just like they're not forming other little capillaries, or there's not a lot of collagen, right? They're just these sheets with some pale eosinophilic to clear cytoplasm and these hyalinized vessels. Great. Yeah. So what's the genetics behind this, and what is it stained for?
So a STAT6 fusion we have seen in these, and then they basically come in. So glomeangioparasitoma, hemangioparasitoma, and SFTs are like two of them. Both of them, I think, shows the STAT6 mutation. And then there's another one that was, I think, CTN. That's from ExpertPath, the CTNNB1 mutation. And
what's that in?
It's like, I think it's like the beta catenin and cyclin D1.
Right, but what tumor is that in?
The
Mangioparasitoma.
Okay. So let's clarify our terminology here. So there's three terms we've seen so far right now. What are they? What was your diagnosis for this case?
Hemangioparasitoma, glomeangioparasitoma, basically.
Okay, so hemangioparasitoma, glomeangioparasitoma, and what was the other tumor?
SFT.
SFT.
Yeah.
So are those 3 the same or different?
So when I was a little going back to the lectures that you gave, the PowerPoint presentation that we have, so sinonasal hemangioparasitoma and solitary fibrous tumor, and they have the similar sort of like genetic mutation that I think you mentioned in that's what where I mentioned the STAT6 fusion.
Yeah, so I would double, or do you have my PowerPoint pulled up right now?
In most sites it says brain soft tissues share identical genetics as NAB2. STAT6 fusion in sinusal cavity can be 2 distinct tumors, hemangioparasitoma, HPC/GPC, and solitary fibrous tumor.
So which one is this?
This is glomeangioparasitoma.
Okay, and what are the genetics? Oh, go to the next slide. Okay, so yes, that's the diagnosis. Conceptually, what are glomeangioparasitomas? What's their cell of differentiation?
Pericytes.
Pericytes.
Yeah.
What are pericytes?
So like
think about it. You've got the answer. Learn about it. Okay.
Can we help her out?
Sure.
Is it like, so the pericytes are the cells kind of around the blood vessels?
Yeah, perivascular.
Smooth muscle.
Yes, yeah, that's why it will stain for SMA.
Right. And so perivascular myeloid neoplasms, this is one of them. They are the the contractile cells around the blood vessels, this is what these differentiate into, right? So yes, SMA, and you'll learn about the genetics of these, okay?
Yeah.
Which is, this is the only site where like HPC
It's different
is
from.
different from SFT,
Oh, okay.
okay? So, but to clarify that this is different, we also now call it, like you're saying, glomangioparasitoma, right? So because we know it's a glomus tumor, the hemangioparasitomas of the brain, those are SFTs, okay? The SFTs of the lung, those are SFTs, okay? The SFTs of the soft tissue, those are SFTs. So because there's this confounding terminology in the sinus case, we usually call them glomangioparasitomas versus hemangioparasitomas. But even though that has historically been used in the literature, but yes, I'm just trying to clarify that these terms are confusing. So I get it. Okay, so let's move on to the next case.
Hi, this is Meghna.
Hi. We lost you.
Can you hear me?
Now we can.
Okay, sorry, I was talking. Jasmine just told me you couldn't hear me. So at low power, you can see the respiratory epithelium that's lining the thing, and you're not pointing to that right now. You were before. Here underneath, you see that there's a separation between the respiratory epithelium and the main tumor. The tumor itself has kind of hypercellular and hypocellular areas and some thin-walled vessels. When you go a little bit higher power, you see that the cells themselves are spindle-shaped cells with indistinct borders and these sort of dark pink, ropey, collagenous areas, or keloid-like ropey collagen. So I didn't see any mitotic figures, or very few rather. I did see some, and no necrosis, and no infiltrative borders around the tumor. So I thought this was consistent with an SFT in this case.
Cool. What are the genetics in SFTs?
It is, it has a STAT6 fusion. Inversion 12, Q13, The fusion is with NAB2 usually. And in terms of IHC, it's because of this, it's going to be positive for STAT6, which is very helpful. And it's nuclear. It's also positive for CD34 in 90% of the cases, CD99 in.
Good. Right, great. So in this case, we do have that nice ropey collagen. We do have these very blunt, bland spindle cells that are also not forming any other structures. They're kind of compressed between the ropey collagen. So maybe just clinically, read about behaviors in these. It's not always easy to predict behavior of solitary fibrous tumors. So they're kind of on the spectrum from like probably indolent to like likely not indolent. But predicting metastasis in these is generally difficult. So great. I'm going to go back really quickly to this case now and point out one feature that we didn't. This is number 2, which isn't specific to this diagnosis, but you often see, which is this going on here. What's this? So you have surface epithelium.
Hemangioma. It's hemangioma, capillary hemangioma.
Okay. Sure. I'm
The
at
ulceration, is that? Yeah.
Right,
so,
right.
Oh, okay. So
Yeah.
that points it more towards a hemangioma because of the ulceration?
No. I'm saying you
okay.
commonly see it. I'm saying if you have what you see in the stroma here, you've got the diagnosis, but then you're like, oh, great, it's ulcerated. Like, that's cool because it often happens. Like, I'm not going to say make the diagnosis because of the ulceration, but I'm going to say the ulceration is a nice soft sign.
Okay.
Yeah. Like, we didn't really see too much ulceration in this case. We didn't see too much, maybe like, oops, I just clicked on the same thing. Maybe like a hair of ulceration in this case. I'm just saying it kind of, it sorts together. It's not specific, but it's just another finding. Okay. Moving on, case 5.
Can you hear me? I have case 5. This is Jasmine.
Mm-hmm.
Okay, so for case 5, we have a low power. It was in like well circumscribed, encapsulated, and then it kind of has this vaguely nodular, like testicular pattern.
Mm-hmm.
And then, and from here, you can see that there's hypo and hypercellular areas.
Mm-hmm.
And yeah, so then if we go higher power, you can see that the cells are spindled. They kind of have hyperchromatic nuclei and no like prominent nucleoli that I could see. They kind of have like blunt ends, I would say, for the most part.
Okay.
And then in the background, there's like a little bit of myxoid stroma.
Mm-hmm. Okay.
So yeah, so then my differential, given the prominent like hyper and hypocellular areas, I was thinking, and because it's encapsulated, I was thinking a schwannoma, and it's a tongue lesion of a 18-year-old male. So even though they're rare, I think that would relatively fit.
Yeah. Yeah, and what feature of the nuclei here do you see?
You mean like the
Like palisating? Is that what you're aiming at?
Mm-hmm. Yeah, palisating, right? They're lined up. They're lined up like a picket fence. And so palisating nuclei in nerve sheath tumors can make you think of a couple diagnoses. One of them is what you mentioned. And then in that setting, what are those structures called? The palisated nuclei with the fibrillary centers.
The Vericay bodies.
Vericay bodies.
Like the Antony A and B areas.
Mm-hmm. And then there's another diagnosis. I'm not sure that that's necessarily what this is, but there's another diagnosis of the mucosal sites that also has palisating nuclei. Does anybody know an alternate nervy diagnosis that's not a neurofibroma?
It's like an intranodal something. Diagnosis. Not the intranodal. Palisated myofibroblastoma.
So just think about other possible differential diagnoses, specifically in mucosal sites of nerve sheath tumors that have prominent palisating.
Okay. Is this the palisated and encapsulated neuroma?
I mean, that would be the differential for me.
Okay.
I know that there's some theoretical ways to distinguish them, but to me, this looks like it does have the 2 different Antony A kind of B areas, but it's also super palisating. So you just might want to read about the differential diagnosis there. Yeah.
Okay, I will. Thank you.
Mm-hmm. All right, numero 6. I think there were 2 slides on 6.
I don't think anyone signed up for this case, just to let you know.
Oh, this is a beautiful case. Somebody take it.
Reham and Christine and I are gonna do it. So let's see 3 in 1. Like if we can beat it, I don't know. All right. So am I moving this or you're moving this? Yeah.
I can move it for you.
Yeah, it's okay. We have a few pieces of tissue here, just like from low power. And then kind of from low power, you also see different areas. Some areas are a little bit more hypocellular, like this, like more edematous right underneath the mucosa and then you have areas that are more densely packed with cells, if we go in higher power, just I guess anywhere in the darker areas, we see kind of, I wanted to call them fascicles, or streaming or story form
Yeah.
maybe, but kind of
Interlacing
yeah,
bundles.
interlacing bundles of monotonous spindly cells. There were no mitoses in here that I could see when I was scrolling around. There was not much of cellular atypia either.
Mhm. It's really cellular, right? Like
Very cellular, yeah, very. And obviously we have these islands or like squamous cell glands that are intertwined in all of very cellular areas. So unfortunately, I call this in the morning a biphasic synovial sarcoma, but I know now that it's not biphasic. It's a monophasic synovial sarcoma. That's what I think.
Okay.
And why is it monophasic versus biphasic versus poorly differentiated? Your fellow is amazing. So she pimped me and was asking me about kind of like what kind of cells do you see? Do you see epithelial formations like glands or something more epithelial like versus just small spindly cells? So yeah, all these smiley faces there. Oh yeah, it is a teddy bear. You guys are right. It does look like a teddy bear. So I don't know if we're on the right track. What do you think, guys? Yeah, or nay? I don't know.
Yeah, we are with you, but we are waiting from Dr. Cipriani.
So how are you going to prove it?
Okay, so we can do spindle or keratin type stains for cells or whatever stains. Yeah.
So what type of stain for synovial sarcoma would you do?
All right. So for this one, if it's monophasic, I was reading that there's this TLI1 or ITL1 or LIT1, TLE1. There you go. That one.
So even before that, even before TLE1,
maybe like keratins, we can do pankeratin.
So keratin and or what's the other?
S100, SOX10.
Okay. So pause. All right. So keratin, if you're thinking synovial sarcoma, keratin and EMA are good screeners.
Yeah.
Because they should be positive in all synovial sarcomas, regardless of monophasic or biphasic. So, okay, pause there. Secondly, TLE, okay, is somewhat specific for synovial sarcoma, but it's shown to be a little promiscuous, which is why you gotta kind of take a lot of things in context. Okay, Faiza mentioned S100. Faiza, why did you mention S100?
Because it's the spindle cell component.
Maybe to rule out others.
I think to rule out biphenotypic.
Okay. Okay, so tell us about that, Heather.
Because S100 and SMA are going to be positive in those since it's neural and myogenic differentiation, whereas I think they're both negative in synovial sarcoma.
And so what's the name of that tumor on your differential diagnosis?
Oh, biophenotypic cynomnasosarcoma, the one that Christina had alluded to.
Okay. So if you're thinking between synovial and biphenotypic, so if you're thinking between monophasic synovial and biphenotypic sinonasal, is that what you're thinking?
Yes.
What is one, so other than immunostains will definitely sort that out for you between the EMA, TLE, and the S100, SMA. Just be mindful that sometimes TLE is less specific. So yeah, FISH would be more specific. But you already mentioned something that I think is quite characteristic, and that's this. So tell me about this epithelium. Like, do you expect this much blooming, like respiratory epithelium in like regular sinonasal neoplasms?
No, it's too hyperplastic. It's too dark,
dilated,
too
proliferative.
Very proliferative, right? It's like very thick and like downward, like bulging. So if you believe that this is the regular respiratory epithelium rather than the epithelial component of a biphasic synovial sarc, which I agree with you. Like, it looks like it's still got cilia, you know, it looks like there's probably a basement membrane. Like, okay, what does that help you with that differential diagnosis?
That leans more towards biphenotypic cyanogenous sarcoma versus synovial sarcoma.
Correct. Okay, so cool. Those are good differential diagnoses. Just learn about the immunoprofile and the genetics, in fact, of both of those, because they both have genetics. The synovial sarc genetics are already in the chat, but the biphenotypic has genetics as well. Does that help clarify? You guys have, did that help? Okay.
Yep, we'll read more on it.
Okay, who wants number 7?
I took that one. Can
Okay.
everyone hear me?
Yeah.
Okay. So on low power, we have a fairly bluish, fairly cellular looking lesion. I think it goes all the way to the resection margin. I don't get a sense that this is encapsulated. And then there are areas that look a little pinker, like they're blushing almost. I think those are due to extravasated red blood cells. I don't know whether or that's significant or not ultimately, but was something I saw. The cells themselves are spindle-celled, of course. They have these sort of long, tapered, fusiform kind of nuclei. They're in some places more parallel to each other. In others, I think you could call them sort of story form, like they're chasing each other around.
I like
Yeah, like a dog chasing its tail, kind of. And then there are these kind of thin-walled vessels, as well as some areas where the vessels are a little thicker walled too. And in general, the cells look pretty well behaved, nice like ovoid nuclei, nothing I think too atypical looking about them. Some of them have more prominent nucleoli, but I don't think that these are too scary looking in general. And then there are some areas of the background. I mean, the background in general is fairly pinkish. Some areas are maybe a touch more myxoid looking, a little bluer, but nothing again too eye-popping. And I didn't see many mites. I saw maybe 2 really good examples, and the rest were more sort of more mercy than justice, and no necrosis. So I think we're dealing with something that's benign, a benign spindle cell lesion of the neck of some sort, and we have a pretty young patient. I was thinking maybe nodular fasciitis, maybe. So I think like stains would be helpful. Other things possibly would be, I guess, a dermatofibroma or a DFSP. And then really, I guess, or maybe even fibromatosis, or potentially even a nerve sheath tumor, although I would put that much lower down. I don't know if we want to chat more about stains or if I'm totally missing the mark on this one.
Very good, very good. So how would your stains help in that differential diagnosis?
Right. So if it really is nodular fasciitis, it would be positive, I think, strongly for SMA. We would have positivity for Vimentin. If there's some histiocytes scattered around, those would stain with CD68, I guess. I don't know how useful that is, but I remember reading it. And then I think the big thing would be negative for CD34, which would help us to rule out DFSP, unless I guess the DFSP has like sarked out into a sarcoma. But anyway, I don't think we're worrying about that here at all. Can we check for like a USP6 rearrangement? Is that something we could do?
You can, and I think that's a great idea. So, right, if you're excluding, S100 is negative, it's not a nerve sheath tumor. CD34 maybe negative, not a DFSP. So yeah, I think the only thing to confirm your suspicion of nodular fasciitis would be the USP6, right? Because any myofibroblastic lesion can have SMA positivity. But
Yeah,
that would be the definitional thing, right? And so just as a pointy outy feature histologically, you already mentioned the extravasated red cells, which I think is helpful in this case. I will also mention this kind of ropey, strappy, pink, almost keloid-like collagen, which could also be helpful in this case.
I wasn't sure if that qualified as keloid-like. So you think it does?
Like a baby. And you talked about what, fibromatosis, I think was your other.
Yeah, I mean, could we do like a beta-catenin?
Yeah,
just see.
Definitely, right? So that you should find beta-catenin again in the nucleus of fibromatosis because they're, yep, exactly. So no, I think that's a great differential. That would be the same as I think. What would help you also with nodular fasciitis might be clinical setting. So what's the time course of nodular fasciitis?
Doesn't it tend to emerge pretty rapidly, like over
Mhm.
a period of a few weeks, usually
Right,
younger patients? I
right,
think it can regress on its own sometimes.
right, right,
Yeah.
right. So if this were like a more long-standing lesion, then you might like slightly nudge yourself towards like a fibromatosis or something else, but if it's rapid growing, so always take those clinical things into context. So yeah, good.
All right. Thank you.
Great differential. All right, what else? Next case. Did this not have anybody signed up for it either?
No.
All right, well, who
There
wants
were
to
3
describe
cases
it
that
now?
didn't have that did not have assignees. I'll email the people who are not signed up afterwards and ask someone to do it.
Okay. Somebody want to at least describe it now?
All right, we'll give it a shot.
Thank you.
Alrighty, so we're somewhere in like oily skin, I would say. We have a lot of sebaceous glands. We have a lot of pilosebaceous units, maybe scalp, maybe face, something like that.
Oh, it says upper lip in the
Oh,
clinical.
upper lip. Sorry, I totally liked you guys. Upper lip.
Little
Okay.
cartilage, so maybe
We
it's
have, yeah, a little cartilage. We have like cysts, keratin cysts, but nobody cares about those, I guess. So then we can go back to the lesion if you want, or whatever this lesion is. It's trying to be kind of well circumscribed. It's not connected to the surface epithelium. It is encasing our little structures like the hairs. It is encasing the hairs and some of the sebaceous glands. It's it's kind of there's areas that are not really cellular, and then there's areas that are a little bit more cellular, but it's not based on edema. I think it's infiltrating down into the muscle, and it's, I think, destroying the muscle. And like, I think these are all entrapped little muscle fibers. The cells, when we go down, are more epithelioid. As Riham said, they're more plump. They're not spindly. We have really prominent nucleoli. I think that there is some pleomorphism. Maybe in amongst themselves, there is some pleomorphism.
Mitosis.
Yeah, mitosis. What else can we say?
some hyperchromasia.
Yeah, hyperchromasia. So definitely, I think it's malignant because it's destroying, subcutaneous muscle or whatever. So I don't know. Is that enough or?
Yeah, no, that's great. So this is a tough one. I think, it's going to be a challenge to determine what the phenotype of these cells are. I agree there. It's hypercellular, mitotically active, hyperchromatic, infiltrative. So I get the picture that this is probably malignant. I also agree. I think this is infiltrating the skeletal muscle rather than like forming skeletal muscle, right? But that's one of the things you should consider on your differential is, could this actually be muscle of tumor? But I think you're right. I think it's just entrapping muscle. And then always in spindle cell lesions of mucosal sites or cutaneous sites, right? Always look at the top. Is there any in situ melanoma? Is there any in situ carcinoma? Is there any sun damage, right? Like, so this is a relatively sun damaged skin. I don't really see much bluish, solar elastosis. Looking at the top, like, I'm not sure we see much like AK or in situ carcinoma or in situ melanoma, right? So we're probably not dealing with a spindle cell, one of those. So we're probably dealing with, oops, sorry, I hate this. It always goes in when I want it to go out and out when I want it to go in. Some kind of mesenchymal type of neoplasm. And so it's going to be a matter of using your mesenchymal type of, immunostains probably to determine what these cells are. So list for me some types of mesenchymal cells that these might represent and what immunostains might help you. We kind of already talked about most of them for other tumors, but start broadly, right? What spindle mesenchymal? Are you muting yourself?
Oh, sorry. I don't know. What should we order?
So start, like, tell me your phenotype of differentiation that you're thinking of.
Okay, so I think that these are right. I don't know if this is the right way. It's epithelioid looking,
Okay.
but so I was thinking like smooth, spindly cell kind of types like S100 and SOX10 probably are not going to yield much value to the diagnosis. Then,
Why?
well, because I kind of link them to, I guess, more spindle type lesions.
Okay.
That's wrong.
Well, in most cases, yes, but just be mindful that you can have epithelioid nerve sheath tumors. You can have epithelioid schwannoma, epithelioid MPNST. You could have epithelioid leiomyomas. You could have epithelial tumors, right? You can have spinal cell differentiation of most epithelial tumors, right? Like spinal cell melanoma, spinal cell carcinoma. And you can have epithelioid differentiation of most spinal cell tumors. So don't ever 100% exclude something only based on the morphology of the cells, because there's a spectrum with like mostly over here and mostly over there, but sometimes they cross over. Yeah.
Okay.
Okay.
So maybe like muscle, like smooth muscle markers, skeletal muscle markers like EMA, SMA. Can we get any of these?
Yeah, sure. So they're all written in the comment, right? So if you want to think about a nerve sheath tumor, S100. If you want to think about something epithelial or myoepithelial, EMA. If you want to think about something muscly or myofibroblastic, SMA, right? So I think those are probably going to help you. There is, I don't want to, without giving the answer away, there is a specific type of, or what I think might be the answer. I honestly, I'm not 100% sure on this case, but there is a subtype of mesenchymal sarcoma that occurs more specifically in the head and neck, mostly on mucosal sites, but sometimes on cutaneous sites of the head and neck that you might want to think about. But otherwise, yes, I think you're probably just going to have a broad differential diagnosis with narrowing it based on your sort of immuno phenotype, you know, whether these are smooth muscle, skeletal muscle, nerve, myofibroblast, things like that.
Okay.
But hopefully he'll help you out. But I think you got the main points, right? Which are it's infiltrative. It's kind of vaguely spindle to epithelioid. There's mitosis, there's hyperchromasia. It seems like probably some kind of malignancy, and we can go from there.
Okay.
Does anybody else have other comments?
I guess like one thing I was wondering is because it looks like it's not really destroying like the adnexal structures, and the fat cells kind of seem to be preserved.
Yeah.
Is there any thought that this might be like a DSFP at all? I mean, I don't think it looks exactly like that, but I don't know if that's something that you would pop on your
What architecture do you normally expect for DFSP?
Sorry, what did you say? Sorry, they're all the pages were going off at the same time for the APQ.
Right. What characteristic architecture do you expect in DFSP?
Oh, like a story form pattern, which we don't really see here.
So that's not 100%, but it's pretty good. Like those really tight packety things. But yeah, the CD34 might help you with that, but the overall architecture doesn't really.
My question was like, I do understand the fact that it is trying to like infiltrating, but it's the way that there is no response around the adnexal architecture, and then there is like hyperchromasia, but then the pleomorphism is like not that it's striking. So, is there a possibility? Could it still be something in like towards a low grade?
Yeah. So when you say malignant, you don't mean high grade.
Yeah,
When you say benign, you essentially mean low grade, right? But when you say malignant, you could mean low grade or high grade, right? So you could have a low grade sarcoma.
I mean, I think the only thing that is giving away from it being benign in my thinking was just like it's because it's infiltrating the muscle, but the lack of like reaction was a little bit throwing me off.
Yeah.
But definitely my first differential was DSFSP, but then the pattern of growth is not the same.
Right.
So, but
yeah, I mean, I think you the problem is things like nodular fasciitis or dermatofibromas are infiltrative at the periphery, right? And so you can't 100% use infiltration in mesenchymal things to differentiate benign from malignant, unfortunately, right? In this case, it's not like a central thing with infiltration out. It's just fully infiltrative. But I think to me, what makes me suspect it to be malignant, which is I think maybe what Christina was getting at also, is just the subtle, like too much nuclear atypia, too much hyperchromasia, too many mitoses. It's like a little much for something completely benign, just in my opinion. But rather than using, desmoplastic stroma as an indicator, because sometimes, like you said, there is no reaction. It's just like going along its merry way. I think, sometimes, I don't know if it's like the epithelial mesenchymal phenotype, but like sometimes mesenchymal neoplasms that infiltrate like don't cause any tissue reaction. Maybe because it's like mesenchyme on mesenchyme. It's just like, okay, whatever. As opposed to when you get carcinoma invading, you get desmoplasia because maybe it's this epithelial mesenchymal, struggle versus intertwined. I don't know. Would you consider an eccrine follicle tumor? Well, is it forming any structures?
No.
Really? Like, I mean, usually for an adnexal tumor, you'd want some kind of structural suggestion, whether it's forming nests, glands, follicles, like, yeah.
It doesn't really have the sort of sweeping fascicles of a low-grade myofibroblastic, but given the infiltration and kind of the cytology, would you consider, and it's also more common in the head and neck,
Yeah, I mean, I think the morphology of that has been, outlined in various papers to some contradicting degree, but I think there are focally some sweeping fascicles. I think it's occasionally been described in the skin, more in the mucosal site, so I would definitely consider it, because I would not know where exactly to put this, so I think you have to have a very broad differential that would include that. RT mentioned low-grade myofibroblastic sarcoma, which I definitely think is on the differential. MET, yeah, I mean, metastases usually don't infiltrate this much, but it's always something to consider. Does the patient have a history of something? Okay. Last two in the last 10 minutes. Larynx.
All right, I took this case. Can you guys hear me?
Yep.
Yeah, so the first thing I did when I looked at this case, I mean, you see three pieces of tissue. I think two of them have pretty good surface. So I went down on the surface and I started looking, and keep in mind we're in the larynx here. I didn't see on low power like any glandular structures. So on that basis, I was sort of thinking we're maybe like more glottic as opposed to supraglottic. There was a couple areas where I was a little concerned about the surface. I mean, it is very inflamed. You're not really seeing like a really great interface between the overlying epithelium and underneath. I think in one area I even saw some pretty prominent mitoses relatively high up. So I was started sort of thinking maybe this patient has a history of some sort of squamous cell carcinoma and had maybe undergone treatment, and now this mass arose. Sort of that was kind of where I was thinking. And then underneath that we have this I guess spindle to sort of plump epithelioid proliferation. It seems to be forming these vascular channels in some areas. Cytologically, to me, it's pretty overtly malignant. I was able to pretty easily find mitoses, and it's very pleomorphic, even multinucleated, hyperchromatic, prominent nucleoli. In some areas, there's also extravasated RBCs. So I was kind of putting this whole picture together in my head of this being possibly a radiation-induced angiosarcoma underlying like a residual squamous cell carcinoma in the larynx. That's sort of where I was at with this.
So, okay, what made you fear that the patient had been treated? Like, what would you think if this were a primary thing? Like, why are you assuming the patient's been treated, I guess is my question.
I guess like part of it is just some of the nuclear atypia is just so bad. It makes me think that there's some sort of radiation effect going on, especially underneath. In cells that are maybe not necessarily associated with the underlying proliferation, but
Yeah, so
it's a good question. I guess I didn't think about that.
yeah, so I think whenever you, yeah, Heather said spindled SCC. So whenever you have something spindled in a mucosal site, sarcomatoid carcinoma is probably your top 10 first options. And so if you see any surface atypia or dysplasia, which I think you did, you saw it, right? You said there were high mitoses. I agree with you. You said there's dyskeratosis. You even said in this area that the surface kind of merges imperceptibly with the spindle cells, which I completely agree with. And so maybe reframe your all of the things you said were correct. So maybe reframe how to think about it in the sense of, if this were a primary lesion, how does that change your thought process versus if this were a radiated lesion? It may or may not change your thought process. But the second thing I'll point out is, you know, you're calling some of these vascular spaces. I'm assuming this might be what you're looking at, or I'm not sure what you were looking at.
It's more evident in some areas, not necessarily there. It also looked like some of the, I guess, overtly malignant appearing cells were like floating within the spaces with the red blood cells. So that kind of, I guess, was distracting me and making me think like maybe this is an angiosarcoma.
Got it. Yeah, no, I think in it, I understand. Okay, so when you see extravasated red cells and pleomorphic cells floating in the blood, yeah, I definitely think that's a good suggestion that you could be dealing with a vascular neoplasm. But whenever you're in a mucosal site, I would argue that based on what we know historically, whatever's going on in the surface kind of trumps some of the morphology below. So, right, if you see in situ carcinoma or if you see in situ melanoma, like, you kind of have to let those be your first guide, you know, because certainly you can get a radiation induced any kind of sarcoma, but you could also just get, you know, acantholysis of tumor cells with bleeding that looks like, you know, oh, like maybe this is a vascular lesion, but maybe it's just artifact, right? So always use all of the features together.
So I guess, I mean, it would be pretty evident on the stains then, like if you did like a CD34 and it was negative, then that would kind of help you rule out that it would be an angiosarc versus like a, I guess, would P40 be positive in these then?
So great question. So in an ideal world, yes, P40, P63, and high molecular weight keratin would be positive in a spindle cell carcinoma. And yes, in an ideal world, all of your vascular markers or most of your vascular markers would be positive in an angiosarcoma. The thing is, while the angiosarcomas are probably more likely to retain those vascular markers, the spindle cell carcinomas or sarcomatoid carcinomas, those two words are synonyms, often lose keratins and often lose P40, P63.
Okay.
I tend, if you're asking about sarcomatoid versus spindle, so I don't like to use sarcomatoid only because it draws confusion into the minds of the clinicians, where then they start asking, is this a sarcoma? So even though to me sarcomatoid and spindle cell are kind of the same thing, I prefer to diagnose it as spindle cell to not confuse our clinical colleagues. Somebody asked about HPV. Does anybody want to flesh that out, or are we good on that?
So just to be clear, we would call this like a spindle cell squamous cell carcinoma, or?
That's what I think.
Okay.
but what do I know?
Well, so then
I guess we should ask him like for a history. Like, does this patient have a history of something, or have they been
Mhm.
treated? And that
Right.
might be useful.
Right.
Sorry, quick question. So when you say that they lose all of the kind of keratin epithelial markers, the only piece of evidence that you're using to call it a squamous cell carcinoma is the fact that there's an in situ or display. Okay.
Correct.
So stains don't help you at all, essentially.
Stains may not help you. If you're lucky, you will see some expression, but most of the time they're negative. So yeah, yes, you have to use that surface as your guide, which is why when they ulcerate, like they often do, it can be extremely difficult to make this diagnosis if you don't have evidence of surface. Yeah. Okay. Excellent. Next.
All right. Can you guys hear me okay?
Yep.
So this is somewhat similar, except this is on the lip. We see most of this looks like just like skin from the chin. And yeah, I think there is a little bit of solar elastosis, sort of a bluish color in the dermis. So there probably is some solar damage here. Moving towards the lesional area, it's more in the vermilion part of the lip. There is a large ulceration.
Mm-hmm.
And, you know, I was looking for some sort of in situ component. I couldn't find anything that's obvious. I mean, it's clear that this lesion in the dermis, which is composed of spindled epithelioid atypical cells, which kind of comes up to the ulcerated portion, you know, it does come up to where the ulcer is, but I'm not seeing any obvious in situ component, although there was an area that maybe it looked a little bit like an AK. But either way, you know, right at that vermilion area, there is this infiltrating lesion, which sort of gets cut off by the slide, or was cut. And it's composed of spindled epithelial atypical cells that are hyperchromatic. I'm seeing right when you go higher power, you see a number of mitoses, some of which look slightly atypical. And it's interesting, it almost has this like bluish vesicular type of cytoplasm, which
Mm-hmm.
I wasn't quite sure how best to, yeah, exactly, make that, make out of that. So anyways, my differential for this was, I mean, first I was thinking this could just be a spindle cell squamous cell carcinoma, similar to what Tanner was saying. I couldn't find any obvious in situ component. I think you have to, in this spot, always think about a melanoma as well. And then another possibility, you know, is an atypical fibroxanthoma, even though we really shouldn't be making that diagnosis here because we're not seeing, you know, the deep part of this lesion. So we
And
can't.
arguably, it's already kind of deep.
Yeah, so I mean, it might already be just something like a pleomorphic dermosarcoma. So I mean, overall, I would want to get stains on this to get a better idea. I would get an S100 and a melanA just to look at melanoma. I would get a P40 and a CK56 or some sort of high molecular weight keratin
Mm-hmm.
to investigate spindled squamous cell carcinoma.
Yeah.
And then just like an SMA, Desmond.
Right.
I know CD10 and CD68 can be seen in that atypical fibroxanthoma. I'm not sure if it is also seen in like a pleomorphic dermosarcoma.
Yeah, I mean, I think of those two as almost the same thing, except
Yeah.
for geographic localization to the dermis versus deeper.
Yeah.
They're both sort of high-grade sarcomas. Yeah. But yeah, no, I think that's great. I think the only, you know, maybe clues you might want to look for morphologically are right. There's like a vague little nesting here. I don't know if you guys appreciated that, right? It's vague nesting.
Mm-hmm.
Vague nesting. I tried to look in the surface too to see if I could find any, lentigo maligna or anything, but I don't look at, you guys look at more melanomas than me, so you might want to scan this surface too to see if you think there's any atypical melanocytes in here.
Yeah, it was hard. There's a lot of these kind of like cleared out cells percolating up, but I think those are all, I don't think they are atypical melanocytes, but
Yeah.
it's not really my area of expertise either.
Mine neither. So yeah, no, I think that's good. When you're dealing with a spindle cell lesion of the, head and neck, well, of skin or mucosal sites anywhere, you really have to have a broad differential sarcoma, melanoma, carcinoma, and use all the possible clues, the location, stains, clinical context. Yeah. So I think that's going to be probably the sort of challenge of these last few. Regarding lineage of differentiation. But yeah, no, I thought they were good cases. I hope you guys did too. Hopefully we'll learn something from him tomorrow. Anybody else?
Thank you.
Thank you.